All right, guys, it's Dr. Muhammad. It is a new day, and that means a new unit. So Unit 1, we talked about ethics. Unit 2, we talked about communication and how to do that effectively with patients. Unit 3, we are finally going to move on to delivering care. This is going to be a short unit as well. We're going to start off with disease prevention and management and going through the different levels of disease prevention. We're going to talk a little bit about palliative care and hospice care in this first section. The next one, we're going to talk about healthcare systems, medical insurance plans, big things like Medicare and Medicaid. And then finally, we are going to round it out talking about healthcare payments and payment models. So we're going to start off by talking about disease prevention and management, and this is going to start with levels of disease prevention. This is huge in medicine nowadays. Rather than treating diseases and managing them, we want to prevent them altogether. So preventative medicine is becoming bigger and bigger, and we all need to know something about it. So levels of disease prevention, we're going to go through the different levels of how we can go about preventing and or treating disease. And that's going to start with primary prevention. Primary prevention is ideally the thing that we do, right? It's preventing disease before it even occurs. Some examples of this are things like diet modification, exercise, smoking cessation, immunizations, all of the things that you can do or that you cannot do to prevent disease from happening in the future. Other examples of primary prevention include things like DVT prophylaxis. You may have seen when you're rounding in the hospitals, everyone's always asking about DVT prophylaxis. Do they have the pneumatic compression boots on? Are they on Lovenox or something like that to prevent DVTs? Those are all examples of primary prevention. We want to do these measures to prevent them from getting that disease, in that case a DVT or whatever else it may be. Something else, an example is enriched flour, enriched cereals, those kinds of things are also helping to prevent disease before it happens. So that is primary prevention. Next up after that is going to be secondary prevention. And secondary prevention is going to be screening and managing pre-symptomatic disease. So the patient doesn't have the disease yet, but we are screening. We want to make sure that we're on top of this, make sure that we're monitoring that they don't get the disease. Examples of this are going to be blood pressure screening, right? Every time you go to the doctor's office, they're checking your blood pressure, they're screening you for hypertension. Pap smears to look for cervical cancer in women. DEXA scans in patients, especially over 65, to check their bone mineral density, make sure they're not getting osteoporosis. All of these are examples of screening and managing pre-symptomatic disease. Some other examples, there's so many that you can think of. AAA screening with abdominal ultrasounds in men over 65 who have smoked. That is a classic board exam question. If there's a man who is 65 years or older who has smoked ever in his life, he needs an abdominal ultrasound to assess for a possible AAA. That is classic USPSTF recommendations. That is an example of secondary prevention, and we need to know that. Moving on, tertiary prevention. Now, unfortunately, the patient has the disease, so what are we going to do? Tertiary prevention is going to be all about treating symptomatic disease to prevent complications. Let's take a step back. Secondary prevention, remember, was screening for and managing pre-symptomatic disease. Now, tertiary prevention is treating symptomatic disease and preventing complications. Examples of that are things like lisinopril for hypertension. That's one of the first line medications. You want to get your ACE inhibitors on board early. Bisphosphonates for osteoporosis. We want to treat the hypertension, we want to treat the osteoporosis, prevent complications like renal disease, prevent complications like fractures. Other examples, diet and exercise for heart disease. The patient already has symptomatic heart disease, but we still want to manage those things to prevent complications. And as you can see based on that example, something like diet and exercise, that can fall into multiple categories, right? We want our patients to have good diet and plenty of exercise as primary prevention before disease occurs, but we also want that in secondary prevention. We want to do that for screening and managing. Even when they have symptomatic disease, in tertiary prevention, we want to focus on things like diet and exercise because that can still prevent complications. So really important to know that some certain aspects, lifestyle modifications, may fall into different levels of disease prevention. And then finally, to round it out, quaternary disease prevention is reducing harm by discontinuing unnecessary treatments. So tertiary, we wanted to prevent complications of the disease. Quaternary, we want to reduce harm by discontinuing things that patients don't need anymore, that may be excessive. Examples of that, stopping lisinopril due to hyperkalemia, preventing polypharmacy and depression. Sometimes patients who have depression are put on multiple medications, and those medications can cause things like delirium or other physiologic changes that can be dangerous. So stopping those medications to prevent those issues is an example of quaternary prevention. Very important that you know that. This is very testable. For example, they may give you a scenario such as a physician is starting a patient on lisinopril to treat their disease, to treat their hypertension. what level of disease prevention would that fall under? And in that case, as we already saw here, it would be tertiary, right? They have hypertension. We want to treat that, manage that, prevent complications by starting the lisinopril. That is an example of tertiary prevention. To really drive the point home, we're going to go through an example and we're going to use type 2 diabetes. And this is going to be high yield. Diabetes, so common, so prevalent, it's going to be very testable. So let's go through each of these levels again, one by one, to make sure that we understand what we're talking about. Primary prevention, preventing disease before it even occurs. Like I already said, things like diet and exercise. That's where that comes in. We want to ensure that a patient has a good diet, is having a fair amount of moderate exercise to prevent diabetes. That is primary prevention. Secondary prevention is screening and managing pre-symptomatic disease. How are we going to do that for type 2 diabetes? We're going to do glucose checks, right? We're going to monitor hemoglobin A1C, those kinds of things to manage pre-symptomatic disease. Tertiary prevention, what are we doing there? Now, remember, with tertiary prevention, the patient has the condition, so the patient has type 2 diabetes, and we are treating that to prevent complications. How are we doing that with tertiary prevention? It's going to be all about treating diabetes with sulfonylureas and trending that hemoglobin A1C. Again, like I said earlier, something like hemoglobin A1C may fall into different levels of disease prevention here. We are monitoring it for secondary prevention to monitor before the patient becomes symptomatic. But once they are symptomatic, we want to continue to monitor it, make sure it's not trending up to prevent complications. So really important to know those little nuances. And then finally, quaternary prevention for type 2 diabetes is going to be something like discontinuing that sulfonylurea because the patient has had numerous hypoglycemic events. Remember, we want to reduce harm. So if the patient has made lifestyle changes, the hemoglobin A1C is getting better, and the sulfonylureas are still on board and they are now causing more harm than good, we want to discontinue them. That is our quaternary prevention. And like I already said, some of these interventions, as we've talked about multiple times, may fall into multiple levels, and you definitely need to be aware of that. Last two things we're going to talk about here are palliative care and hospice care. Ideally, we want to prevent disease before it happens, of course. And after that, we want to manage disease so that it doesn't get bad. But unfortunately, disease does get bad to the point where patients are approaching the end of their life. And we need to know how to manage this and how to care for this. So that's going to start with palliative care. Palliative care is focused on improving the quality of life of patients by focusing on providing comfort and relieving pain and suffering. And those two aspects are so important, so key to know. You're going to improve their quality of life. How? One, by focusing on providing comfort, and two, by relieving pain and suffering. One example of this is patients who are on chronic opioids, perhaps because of chronic pain or chemotherapy. They are receiving high doses of opioid medications. And what can that cause? That can cause constipation. So for those patients that are on chronic opioids, we want to give them medication for constipation. The last thing to know about palliative care, and I've mentioned this before, it is interdisciplinary. This is going to involve multiple different specialties. It may involve their PCP, nursing, home health aides, religious spiritual leaders, all of those kinds of things. The next step beyond that is hospice care, which is the true end-of-life care. What is hospice care? It is essentially palliative care for patients with a prognosis of less than 6 months to live. So it is patients who are truly ill, they are going to pass away, they are going to die, and we want to make sure that we are doing right by them and taking care of them appropriately. The big thing that happens with hospice care is that the patient and the family have decided to stop curative or life-preserving treatment. We are not trying to fix things, we are not trying to make things better, we are just trying to maintain when it comes to hospice care. And this can be provided in a hospital, in a skilled nursing facility, or at home, right? If the patient is most comfortable at home and they're on hospice care, then we want them to be at home. We want to do all of the things, provide all of the services that we can to make sure that they can be managed at home. And just like palliative care, we want to provide maximum comfort and, very importantly here, while preserving dignity. Yes, of course, we want our patient to be comfortable, we want to relieve their pain and suffering, but this is a very terrible time in their lives. They don't have much time left to live. We want to make sure that we are preserving their dignity, respecting their wishes, those kinds of things. It is very important to know this on the exams, and very important to know this because you're going to be seeing palliative care and hospice care patients in your hospitals and in your clinics. Quick recap to make sure that we've got this all down pat. This is Unit 3, where we're talking about delivering care, and we started off with disease prevention and management. We started off with the levels of disease prevention. Remember, primary prevention is preventing disease before it even occurs. Secondary prevention is screening and managing pre-symptomatic disease. Tertiary prevention is treating symptomatic disease to prevent complications. And quaternary prevention is reducing harm by discontinuing unnecessary treatments. Two really important examples you need to know for that: high blood pressure and diabetes, as we talked about right here. Palliative care is focused on improving the quality of life by patients. How are we doing that? 1, by providing comfort, and 2, by relieving pain and suffering. Unfortunately, if a patient gets to the point where they have less than 6 months to live, they are put on hospice care. It is both the patient and the family who have decided to stop curative and life-preserving treatment. We want to provide maximum comfort while preserving the patient's dignity. That is the end of this section, and I will see you in the next one.